and welcome back to the channel. I'm Chelsea Brown, physical therapist and founder at Reboot Concussion Recovery. I specialize in post-concussion treatment, dysautonomia, and vestibular conditions. In this video, we're going to dive deeper into dysautonomia or dysregulated autonomic nervous system. If you need more details on the autonomic nervous system, check our last video out first and then come back here. So, what is dysautonomia? We said dysautonomia is an umbrella term for dysregulated autonomic nervous system. So that autonomic nervous system is responsible for things that should be happening automatically. Think heart rate regulation, blood pressure, sleep cycle, hormone, digestion. Those sort of background, we don't think about it, they just do. When we have dysautonomia, that's not happening the way that it should, and therefore we're having these symptoms such as racing heart, lightheadedness, dizziness, poor sleep, constantly fatigued, poor digestion, food sensitivities that don't really make sense. The list could go on and on and on. Now we're going to focus more on these dysautonomia or dysregulated autonomic nervous system as it pertains to your ability to be upright. So again, dysautonomia is an umbrella term. There's a lot of things that fall under that umbrella. We're going to focus on more of those orthostatic conditions. So in the normal individual or a healthy regulated nervous system, when you go from laying down to standing, there's a quick elevation in our heart rate in that first 60 seconds. And that is because gravity has changed. Now our body's working against gravity. Initially, our blood flow will go down to the feet. It's about a third of our blood flow. And then heart rate will increase rapidly, flush it back up to our abdominal in our head so that our vital organs continue to get the oxygenation that they need. So when we do these position changes, you would see a quick spike in heart rate, and then it would immediately come right back down and level out. That person's not going to notice it. They're not going to feel anything. They're just going to go about their day. When we're having a sluggish or poor responding autonomic nervous system, we feel that change. So when you stand up, it might not respond immediately. So you're going to feel that blood pooling distally. We sometimes feel swelling. The cement leg changes discoloration in our distal extremities, hands and feet. Racing heart, because now it's going to have to respond. So it rapidly overcompensates and the heart rate elevates significantly, things like that. So that is a tall tale sign of a dysregulated nervous system. Now, those symptoms aren't only going to be present just when you stand up. Sometimes they get worse the more that you stand, because now your body's trying to work harder and harder and harder against gravity. It just does not do that well. So if you're standing in line at the grocery store for a prolonged period of time, you start to feel more and more symptomatic. Up and about for more of your day, the later on in the day, the worse that you start to feel. You feel a lot more fatigued. These are some signs or some symptoms that patients with dysautonomia will complain about. The more exertion that you do, the harder that you work, the harder you walk, the more try to push through and go to the gym and do more exercise, typically the worse that you feel. And it might not be in the moment of exertion, because again, sometimes people really like exertion. It makes them feel happy, makes them feel good. It's going to be the couple hours after where the body is still trying to play catch up from that exertional activity that you had. So how does one get diagnosed with dysautonomia? Initially, it took a long time. We were talking, I think, 4 or 5 years that people would be complaining of these symptoms before they would get diagnosed. They'd, have heart palpitations and racy heart symptoms. So they go to a cardiologist. The cardiologist would be like, your heart looks fine, structurally looks good. Maybe go see a neurologist because you have those headaches. Or maybe you go see a GI because those stomach symptoms seem weird. And they would just toss provider to provider to provider before somebody put all those pieces of the puzzle together and gave them the diagnosis of dysautonomia. Fortunately and unfortunately, COVID-19 has increased the number of cases of dysautonomia. That viral infection has caused a lot of people to have dysregulated autonomic nervous systems, I being one of them. And therefore, we've actually become more aware. Providers have become more educated, so that diagnosis to dysautonomia is not taking as long as it once did. So viral infections can be one reason for secondary dysautonomia. We can see it from trauma such as brain injuries, concussions. We can see it also from prolonged periods of bed rest. Now, it's not the bed rest and the inactivity that is causing dysautonomia or being deconditioned, but post-surgery, post-other illness or something that decreases your time spent against gravity, right? You're going to be less tolerant to that, and that can start to lead to dysautonomia. Usually It's a plethora of those things all put together. Trauma and illness usually lead to bed rest. So it's hard to say which one of those things is really the primary cause there. But again, these are all sort of secondary dysautonomia. So where there was an initial thing that then led to there also being dysautonomia down the line. It doesn't really matter the cause. Was it COVID-19? Was it concussion? Doesn't matter. Treatment that can be the same. Getting you the correct diagnosis and getting you treated, that is going to be most beneficial. So how do we diagnose dysautonomia? Primary is going to be a lot of putting the pieces of that puzzle together of all those symptom complaints. So again, like I said, a lot of times previously it was pass provider to provider to provider, but you need the provider that's going to listen to all of those things. So linking your racing heart and lightheadedness and dizziness and GI upset of weird symptoms and weird tolerance to certain foods together to realize that, hey, these aren't all random, but these are important in the big picture that this individual probably has a dysregulated nervous system. So that being said, if you're looking for a diagnosis and going to different providers, don't leave out any of your weird symptoms that you don't think would be relevant, because they are usually relevant in that big picture. And as long as you have a provider that is listening, they will help put that piece of the puzzle together for you. So I always say, anything else, anything weird, anything funky, can't quite put your finger on, but you've kind of been experiencing, that is one of my questions in all of my evaluations, because usually that actually is the final piece to the puzzle that I'm looking for. And a lot of times people don't think to mention it because they don't think it's pertinent to that provider. All the information is going to be pertinent because we're looking at a whole systemic view instead of just the neuro view or just the GI view or just the cardiac view, right? We're putting it all together. So we're taking your symptom presentation, how you feel, activity tolerance, tolerate your usual day-to-day, things like that. And then the big piece is looking at your vitals going from a supine position to a standing position. So when you move to an upright position, how does your body respond to that? So there are two different ways that we can test orthostatic tolerance. One is our sort of budget-friendly, very easy to do. Most providers, PT, cardiologists, neurologists, could do right in clinic with you as long as they have the appropriate time. It is slightly time-consuming because, again, like I said, it's heart rate response and vital response to prolonged periods of upright positioning. So if you're getting a vitals assessed and they only took your vitals for 3 minutes, that is not going to be enough to look at the whole picture. So that is one, super easy, really helpful, and perfect to getting started with treatment. We do not need the big fancy testing to get you going on the right track. The big fancy testing is the whole autonomic workup with a tilt table test. That is technically the best way to go about it, but there is not a big difference between what we see on tilt table and what we see on an autonomic orthostatic testing in clinic with just heart rate and blood pressure. The tilt table does take out your active assist. So again, when we're doing a stand test where in the clinic active stand test, somebody is laying down for 10 minutes they're laying down for 5 minutes and then they are going to be standing for 10 minutes. We're looking at heart rate, blood pressure, and symptoms throughout that whole 15 minutes and how it's responding to that activity. What you have to be wary of in that is taking out the body's ability to compensate on its own. So if you're somebody who doesn't like standing for prolonged periods of time, you're a fidgeter, you're a swayer, you rock forward and back, you try to take a couple of steps, right? You're using those active pumps to help bring blood flow back to the core. So it's a lot of cueing to stand as still as you can. What the tilt table test does, it takes that out. It takes the active assist and the active pumps out of the equation because you are strapped to a table that does that passively. And it takes you from supine and the table tilts until you're upright against gravity. And again, you're just strapped to the table. You can't use those pumps to help. So that is where it gets to be a little bit better. But in the Boston area, ability to get in for a tilt table test, I think I last heard was about 12 months to 18 months. So ideally by that point, we're really far through our protocol and you're not complaining about these symptoms anymore. And sometimes what happens is I start somebody on the protocol. We did an active stand test. They presented with a certain classification. And as they're getting better, they get to a tilt table test and they present a little bit differently. It was a year later. That's going to happen. And that doesn't mean that what we did was wrong. They're still feeling better. They're still functionally able to do more. It's just that it took them longer to get in for the true testing. And it didn't change the treatment the rest of the way either. So you can get really good work and really good foundation laid without getting into a tilt table test by just using an active stand test that can be done in clinic with any provider that can take blood pressure and heart rate. So that is how we classify. So we use that active stand test or tilt table test where we're looking at the change in vitals. So we're looking at how does your heart rate look and blood pressure and symptoms when you're laying down to how does it look when you're standing after a prolonged period of time. There are 4 different classifications when we're talking about orthostatic tolerance. Now it's important because sometimes people use these different classifications interchangeably. And I like to use a couple different analogies when talking about this because it is most common that we see our first classification being POTS being used interchangeably with dysautonomia. As a reminder, dysautonomia is an umbrella term. It classifies everything. Dysautonomia are our dogs. POTS is our golden retriever. Orthostatic hypotension is a lab, right? So not all dogs are golden retrievers, but all golden retrievers are dogs. Again, it's like if you're a coffee drinker, coffee encompasses a lot of different types of coffee. This would be our pour-over coffee. Orthostatic hypotension would be a latte. So not all coffee is pour-over coffee, but pour-over is a type of coffee, right? It falls under the coffee umbrella. So those are a couple different analogies what you can think about where we have an overarching term, coffee, wine, right? Things like that, where there are a lot of different branches that fall under that. You can't use each interchangeably. One describes the all, but one underneath does not overarchingly encompass everything else. So again, let's go back. What is POTS? Because I've kind of went on my rampage here. So unfortunately, POTS is commonly most talked about. You'll see it a lot on social media. It is not actually the most common form of dysautonomia, but it is the most commonly labeled and labeled incorrectly. So that's why I kind of went on that little sidecar. So we want to make sure when we are giving people diagnoses of dysautonomia that it is correct. I've had people say that, hey, I got this new diagnosis since I went to see X provider. They say I have POTS 2. I'm like, no, you don't have POTS 2. You just have dysautonomia. That was poor use of the word. So POTS is a high heart rate response as a primary compensation to being upright. So that means after prolonged periods of standing, your heart rate elevated greater than 30 beats per minute and stayed elevated with the absence of a blood pressure change. So that is POTS. Our next is orthostatic hypotension. So that is going to be a decrease in blood pressure with prolonged standing. Our systolic or top blood pressure number will decrease by 20 millimeters of mercury or more, and our bottom systolic number will decrease by 10 millimeters of mercury or more. There might be a secondary increased heart rate with that, right? Because we still need to figure out a way to get blood flow back to the core. So sometimes after that drop in blood pressure, we will see heart rate climb. The blood pressure takes primary in classification here. And these classifications are really only important when we get into the side of medical management. So if we are taking medication to manage our symptoms, if we are taking medication that is not addressing our primary compensation, we usually see these individuals that are have increased symptoms or don't tolerate the medication. And you're like, why is this happening? Why do I feel worse when I get meds that are supposed to make me feel better? And that's because that med was not appropriate for them. It was not appropriate for how their body was primarily compensating. Our third is orthostatic hypertension. So that is going to be the opposite of hypo. It's going to be an increase in blood pressure with prolonged standing. So again, that systolic number will increase by 20 millimeters of mercury or more. So that top number and the bottom would increase by 10 millimeters of mercury or more. It doesn't need to be both, it's just one or the other. And this has been on the rise. We've seen more with individuals with long COVID, that their primary response seems to be this orthostatic hypertension. And then the final classification is going to be our orthostatic intolerance. So these are the people that are really, really symptomatic, but honestly have the hardest time getting diagnosed because they don't fall into any of the categories. They don't have a high enough heart rate response to meet the POTS diagnosis. They don't have significant blood pressure changes to meet either the hypo or the hyper classification. But again, usually they're the most symptomatic. And you know why? Their compensation sucks. Their body isn't compensating well. They're not getting this change in vital sign to bring blood flow back to the core. So they feel really nauseous when they stand up because their abdominals don't have enough blood flow, they don't have enough oxygenation, and it gets worse the longer that they stand. They can feel spiky, racy heart, but it's not racing high enough, right? Lightheadedness, dizziness, all those things. So those are going to be where that symptom presentation and paying attention to their change in symptoms when doing the testing is most important. I've oftentimes seen these people swiped on the rugs. They got into autonomic testing before seeing me and they're like, yep, they said nothing's wrong. We do the active stand test and I'm like, oh, well, yeah, you don't need any classifications, but that symptom presentation is really significant and you're going to respond well to this conservative treatment. So let's get you going on that. So just because you don't fit the classification from a vital signs perspective, that could still mean there's dysautonomia. It's just your compensations actually aren't great, and those usually are worse. From a symptom perspective, does not mean they don't have a hard time responding to the conservative treatment. They actually respond really well. It's just that they need the guidance to get there, and a lot of times people dismiss them as anxiety or things of that sort, or it's a GI thing, it's not a cardiac, blah, blah, blah. Whatever it is, they get tossed around a little bit more, but know that those people still respond really well. That is you. Stick around. There's going to be more videos to help you out. So that is a brief overview of our 4 different classifications for orthostatic tolerance. Again, finding that classification is really important when we're talking about medication to manage your symptoms. Ideally, we're not really getting to the point of medication, although some people definitely need it, and I am not anti-medication for that, but the conservative treatment approach is super effective and really helpful for these people in getting back to the things that you want to do. Just because you have a hard time going to the grocery store now doesn't mean running is out of the picture for you down the line. It just, you need the right guidance to get from where you are now to where you want to be. That is why I created my Reboot coaching program. This helps guide individuals from where they are currently to their goals and where they want to be down the line. We've taken people to marathons, getting back to gym programs, weightlifting, competing in deadlifting competitions. Like, the sky's the limit as long as you put in the work and someone's there to help guide you along the way. If that's something that you're interested, use the link down in the caption to schedule your free consultation call, and let's get you going. Make sure that you like and subscribe to the channel. Our next video is going to dive a little deeper into some of the conservative treatment approaches for dysautonomia and that low-hanging fruit. So make sure you are subscribed so you can get notified when that video drops. Thank you for watching.